Another ACE surgeon, Dr. Giriraj VIBHUTE, the vitreoretinal consultant at M.M. Joshi Eye Institute. So he'll be speaking on the secondary IOL options. What do VR people do from VR point of view? So he has done a lot of skill fixated IOLs. I'm sure he'll be able to deliver his best. Over to you, Dr. Giriraj.
Thank you, Srinivas sir, for introduction and for including me in your IC. And modern cataract surgeries are refractive surgeries, but yes, sometimes problems happen and sometimes we do end up with aphakias, and most of the times it is referred to us for further management. What do we do in our regular practice is, it is not always necessary to give a secondary IOL. This lady who was operated 20 years back and who is very happy with aphakic glasses for last 20 years, I would not recommend a secondary IOL for her. So choosing patient is also one of the first things which we do. Aphakic contact lenses can be an option, but according to the study I have included, the most common reason for secondary IOL implantation was to relieve the discomfort caused by spectacle or contact lens use. So in such patients, you can offer the secondary IOL or the spectacle or contact lens independence. So now that we have decided about a secondary IOL, what needs to be done? So if a problem is happening right away, and if you have a vitreoretinal surgeon in the next OT, it can be done in the same sitting, or it can be a deferred procedure. It can be done in a second sitting. Studies have shown that there are no visual, significant changes in the final visual acuity in either of the sittings. So you can do it according to your convenience. So if things are going out of your hand as a cataract surgeon, triple S is the technique which you follow. Triple S means stop, suture, and then send. That is, you can refer. Stop at that time, don't fish, don't try to do anything which is you are not comfortable with, and then you can send the patient. If sulcus is available, obviously it is the ideal choice, but if it is not there, then the conventional 2-point or 4-point fixation comes to our rescue. 2-point fixation, most of us know. Because of time shortage, I have just included a picture. We know under this scleral flap, railroading is done, 90-prolene is used, and sutured under the flap. But sutures have, the 90-prolene has its own life, and younger patients might require multiple surgeries due to suture erosion or due to suture breakage after some time. So to tackle that, Dr. Satyamurthy sir has taught us this technique with the help of Gore-Tex suture, which is a monofilament porous suture made of PTFE material, that is polytetrafluoroethylene material, which has a life of around 25 years and more. It is commonly used in vascular surgeries. Here we use the AIOS IOL, which has 4 eyelets. The Gore-Tex suture is passed through 4 of these eyelets, and the distance in between the 2 eyelets is 4 millimeters. 2 millimeters away from the limbus and 4 millimeters apart, two openings are made through which this Gore-Tex suture is brought out with the help of intravitreal forceps, which is repeated again on the other side also. And then the 4-point fixated IOL, it sits nicely into the place. You can suture, you can tie a knot under the conjunctiva itself. The material is soft and malleable, so it does not cause pricking sensation to the patient. You can just try to drag the knot towards the scleral side. And yeah, that is how it is done. Then the other techniques are the Chariot's tunnel technique, which is again a commonly used technique where you bring out the haptics of a 3-piece IOL and then you place it inside the tunnels, which are made with the help of either 26-gauge needle or cannula, which is the Chariot's tunnel technique. The modification of this is you can fix these with the help of a glue also. That is glued SFIL. Yamane's technique is similar to it, where you use cautery. Because of time, I will not show this video. The 4-flange Canabrava technique is popularized again as dumbbell technique, where you cauterize the edges of a 6-prolene suture. We use it, a little modified version of it, in closed globe internal fixation, where this one-sided dislocation of SFIL had happened 7 years after the primary surgery because of trauma. What we did was, after vitrectomy, with the help of chandelier illumination again, we passed a 6-prolene suture 2 millimeters away from the limbus inside the vitreous cavity. And then intravitreally, we passed it through the SFIL eyelet and brought it out. So it is being passed through the SFIL eyelet intravitreally. Then it is brought out through a corneal opening and flanging is done. So you form a bulb so that it will sit nicely into the haptic, into the eyelet of the SFIOL, and you do the same thing on the other side also. The latest are scleral tuck IOLs, which are gaining popularity in our hands. So it has a T-shaped haptic, it is hydrophilic lens, foldable lens, which is an advantage. Either you can insert it superiorly or temporally. This is the relatively older video. Nowadays we are using temporal injection, and 23 gauge needle also can be used instead of 23 cannula. You just hold it, bring it out on either side. It sits nicely and surgery finishes within 15 minutes if it goes well. It has its own problems. Sometimes the T might break and all, but if it sits nicely, then your work is done in 10 to 15 minutes. I'll just show this. So you hold it, it has its own specialized forceps. So kind of a handshake, you just hold it and bring it back. So this was our own study, which is about to get published, comparative study of sutured decentration and tilt. So we compared it with 2-point fixation scleral technique with the help of Antirion machine and ImageJ software. So the study revealed almost 43 cases in both the groups, and the CMT group had significantly lesser incidence of decentration and tilt both. So yeah, with that, I thank sir, and I hope I'm within time. Thank you.
Fantastic. Thank